In the past 10 years, we've learned an awful lot about the difference in treating acute versus chronic pain. So today's blog, we're going to give you our top 5 tips for managing chronic pain. Number 1 is to understand it. It's important to understand because in the US alone, 70 to 100 million people suffer from chronic pain. So the mechanism of any pain starts with peripheral irritation, causing a prostaglandin release, causing irritation to the first order neuron and nociceptors, which then transmit that to the spinal cord. In the spinal cord, that first order neuron synapses with the second order neuron, releases substance P, and sends that message through the spinal thalamic tract up to the thalamus and eventually the cortex for interpretation. Well, the cortex can then either decide to become excited about that or inhibit that sensation and send that back down through the descending pathway. So one thing that we need to recognize is that any potential perceived threat, the brain can choose to either habituate that or sensitize for that. Habituation is much like forgetting your sunglasses are on your head or forgetting about the clock that's ticking in a room. Sensitization, on the other hand, is like walking through a spider web where all of a sudden now you think there's something crawling on you for the next 5 minutes. And both of those are based upon the perceived level of threat. That having sunglasses on your head or a clock ticking is a low level of threat, so the brain suppresses it. Whereas the spider bite is a higher level of threat, so the brain sensitizes against that. And we need to recognize when the brain has sensitized. So recognizing that unhealthy belief, which is the U in the OPPQ or ST. A patient's unhealthy belief, especially that pain is bad and movement is bad. Sometimes the pain drawing can give us a little bit of an indication. None of us are looking forward to seeing this patient. When there's abundant or non-anatomic drawing, we know that there's a potential problem there. And there's also the yellow flags that the patient believes that something is bad, that something is wrong with their body, or this pain is really having a massive impact on their life. Maybe they have some bad attitudes or some other stressors, and those yellow flags are clues to us that this could be chronic pain, obviously in addition to the duration of being there more than 3 to 6 months. Once we've identified that this patient probably has chronic pain by the duration and by their attitudes and yellow flags, now we need to identify where do we target our treatment. And there are 3 potential sites. That chronic pain can come in the variety of nociceptive pain. This means that the peripheral nociceptors have been chronically irritated. These are things like lower back pain or osteoarthritis. It's usually neuroanatomically congruent pain that's provoked by movement. It's sharp, it's intermittent, and our orthopedic testing picks that up. The second type of pain is neuropathic pain. This could involve the first, the second, or the third order neurons. Somewhere in the nervous system, something's been irritated for a period of time, and now we have pain, oftentimes radicular pain. So this could be a complex regional pain syndrome, a peripheral neuropathy, postherpetic neuralgia, one of those types of things. And these pains are usually provoked by nerve tension tests, an upper extremity nerve tension test, a straight leg raise. It's usually anatomically congruent as well. And the third type of sensitization is the central sensitization. This means that pain's been around for a period of time and our brain has upregulated that process. These are things like fibromyalgia and TMD. They're usually not neuroanatomically congruent, and it's usually provoked not by movement or nerve tension testing, but rather by stress. So identifying that target is very helpful. Chiropractic offers this chronic pain infographic. I've attached a link in the blog that you can download it to take a look at all the qualities and parameters to help better direct our treatment. And speaking of treatment, 2 things that we can do. Number 1 is passive care. Things like spinal manipulation. Yes, that is a very effective tool for chronic pain. And its greatest effect for chronic pain is providing some temporary relief so that the patient can move to active care. Because when it comes to chronic pain, it's usually not the peripheral lesion that's the problem. It's the way the patient is thinking about that pain that's the problem. So in this case, our words, our education, and our stimulation to get that patient active is more essential than what we're going to do with our hands on trigger points or stuck joints. And that means that we're promoting active care. That includes pain neuroscience education, exercise, and ADL advice. For pain neuroscience education, there are 4 components that are essential for us to share. Number 1 is that the patient understands sensitization and habituation. That one thing that we can explain, it's like getting jumped on the end zone after scoring a game-winning touchdown versus getting jumped on the street by a group of thugs. Similar mechanical stressors, but one goes almost unnoticed and the other one can cause pain for weeks or months because our brain has perceived one as much more threatening than the other. So patients need to understand that And they need to understand that happens frequently when pain's been around for 3 to 6 months and beyond. So our brains tend to upregulate that. It doesn't dismiss it. Usually we upregulate or sensitize for that chronic pain. And then we need to let the patient know that they need to take part in this process, that it's not up to us to strip out trigger points and adjust joints. It's up to them to begin thinking about that pain differently, to retrain their faulty beliefs and behaviors. And the number one belief that they need to retrain is that pain is not bad. There's a big difference between hurt and harm. Yes, it's going to hurt for you to go walk steps and to go back to the park. It's going to hurt for you to chew, but that doesn't have any relationship to any harm that's happening or the degree of harm that's happening. One thing that you can do to deliver that information, pain neuroscience education, is if you're in Chiro Up, if you prescribe a chronic pain condition report to a patient, it's going to explain all of that. But maybe they just have knee osteoarthritis or a lumbar disc lesion or stenosis that's been around for a while. You can prescribe the ADL for chronic pain, and in that case, they get the pain neuroscience education that can help you deliver your job a little bit more easily. Then the other thing that we want to do is to get that patient moving as quickly as possible, which is two components. Number one, identify where they sit on the spectrum of activity, and number two, identify where they want to go on the spectrum of activity. And so then we need to move them there slightly and make sure that we incorporate their goals. If they want to get to the point that they can run, then that's our goal. We're going to challenge their unhealthy beliefs to let them make sure that they understand that it's okay to have some discomfort, and making sure that that pain doesn't dictate their level of activity, that the sets and reps and duration should have nothing to do with the discomfort. Now, sharp or radiating pain may be a different story, but discomfort has to be worked through in chronic pain patients. And we identify where they stand on that spectrum and move them slowly. Sometimes that's holding the reins so that they don't run off with too much activity, but most of the time it's nudging them along so that we get them a little bit more active. And finally, the ADL considerations that we're going to take is number one, redirecting their attention. Simply looking at a painful part is going to make it hurt worse than looking at the opposite side. There's research to tell us that. So having the patient refocus their attention. If they walk in the park and their knees hurt, think about how good your fingers feel. And if that patient is having a back pain when they're sitting in a computer, they can focus on what it would feel like to change a Rubik's Cube. A complex thought process will take their mind away from the pain and divert that blood supply, divert that attention, and help to change things neuroplastically back to where they belong. We also know there's a big correlation between obesity, between eating too much, excess caloric intake, and inflammation. And chronic inflammation doesn't help any pain, especially chronic pain. Obviously, we want to get that patient active, as we've talked about with the hurt versus harm theory. And patients who have chronic pain often have a big connection to insomnia. So we're going to teach them that 7 to 9 hours of sleep is important. Stay away from your electronic devices before bedtime. The foods that you shouldn't be eating before bedtime. Chiro has a great sleep infographic that you can give to the patient. Attach that as an ADL to educate them as well. Counter-irritant creams can be helpful in a lot of those passive things, including spinal manipulation, which is helpful short-term and helpful long-term. In fact, the CCGPP Clinical Compass just put out an awesome paper that talked about the guidelines for how long we should treat a patient in an acute versus a chronic setting. There's a benefit, but again, let's remember things like that and counter-irritant creams should be used to get the patient active, to help suppress their discomfort to the point that they can then take charge of their health and be an active participant in their own recovery. CBD oil helps, especially for pain that's of second-order neuron type pain. And finally, sometimes it takes a multidisciplinary approach. We know that medication is not a good answer for chronic pain. Rarely does it work because the patient becomes used to it and it's not something long-term effective. But sometimes we can bring in a social worker, a psychologist for some cognitive behavioral therapy, helping us with a little bit more potent way to change that patient's thinking. I hope that I've been able to change some of your thinking about chronic pain. I hope I've been able to relay some tips that you can use. Visit chiroup.com. You can prescribe the condition report for chronic pain or include the ADL for chronic pain for any of your patients. If you're not currently a subscriber, visit our site today and get started with a free trial. Thanks for watching.